Hi everyone, I'm Dr. Roman and I am a board certified hematologist oncologist, and let's talk about malignant brain tumors. Now this is more of an introduction to malignant brain tumors. I'm going to go over the more common types and I'm going to mention briefly the more common treatment options that we have for them. So with that being said, let's get started. As with all my videos, this is for educational purposes only. I am not providing any medical advice. All right, let's start off with some basic facts about brain tumors. First of all, brain tumors can either be benign or malignant. That's the first thing we need to know. The second thing is that the majority of malignant brain tumors in the brain originated somewhere else. I want you to think about that. The grand majority of the times that we find cancer in the brain is because it is metastatic disease. For example, lung cancer that traveled to the brain or breast cancer that traveled to the brain. And that's why it's very important when we see these brain tumors that we think of the possibility of it being metastatic disease from somewhere else. Now, a glioblastoma is the most common primary malignant brain tumor. Primary because starting in the brain. So the most common cancer that started in the brain is a glioblastoma. Now there's another type of tumor which is called a meningioma. It's exceedingly common. I mean, it's very common. We see this all the time. And it's a tumor that started on the meninges or the coverings of the brain. Okay, that's why I'm calling it the most common intracranial tumor, because it's not necessarily inside of the brain. And the good news is that the majority of meningiomas are benign. Now, the most common risk factor for the development of a brain tumor is prior radiation therapy to the brain. So just something to keep in mind. I threw this in here because I found this interesting, and that is that the data on radio frequency radiation is inconclusive. This means the radiation that, or the heat generated from cell phone use, we really do not know if there's a link with the development of brain tumors. So there you go. And usually, not always, but usually there is no true family history predisposing a person to brain tumors. All right? So now let's move on to the anatomy of a brain tumor, but at a cellular level. And for this, we have to understand the cells within our brain. Just know here in blue, we have a neuron. Okay, so this is a neuron. And then the other cells that we have in our central nervous system are our glial cells. For example, an astrocyte or an oligodendrocyte. These cells have several functions. For example, they protect our neurons. They insulate our neurons. They nourish our neurons. And also they work or function as nerve glue. They keep our neurons together. So if you were to develop a tumor, for example, within an astrocyte, then you would develop an astrocytoma. If you were to develop a tumor within an oligodendrocyte, then you might develop an oligodendroglioma. So really it depends on where this cancer started that it will derive its name. All right? So this here is a picture of the brain using an MRI scan. And as you can see, you clearly see this tumor that is inside the brain, and it is pushing the brain here to this side. And this is an MRI scan without contrast, but you can clearly see the tumor, that there's a pretty large tumor within the brain. And this is one of the diagnostic tests that we use to diagnose brain tumors. So if you remember from our anatomy slide, at a cellular level, we spoke about our neurons and our glial cells. Well, neurons function as our signal transmitting cells. Okay, very important cell, obviously, within our brain. And if you develop a tumor, depending on the location of the body, these neuron tumors can be called either a gangliocytoma or a neurocytoma, and there are others. Just know that these are extremely rare. I've been an oncologist for over 18 years, and I cannot remember the last time I saw one of these tumors. Now, our glial cells, remember, like the astrocytes and the oligodendrocytes, that again function as insulation, nourishing our neurons and protecting our neurons. These cells, once again, just as a reminder, are astrocytes, oligodendrocytes, and ependymal cells. If you develop a tumor within an astrocyte, it's called an astrocytoma. If you develop a tumor within an oligodendrocyte, it will become an oligodendroglioma. and a tumor in the ependymal cells, it'll be called an ependymoma, and there are others. Now, the important thing here is that tumors within our glial cells are much more common. I have seen many of these, so that's why I want to try to concentrate on those, because by far, those are the ones that we tend to see. Now, there are other tumors within our brain that we quite frequently see, like, for example, a medulloblastoma. This is more of a pediatric tumor because it's an embryonal type tumor. Also, a lymphoma that starts in our brain or spinal cord, which is called a primary CNS lymphoma. We tend to see this more in patients who are immunocompromised, but we also see them in patients who are immunocompetent. So our immune system has a lot to do with these lymphomas. And as we already mentioned, meningiomas, which are on the outside covering of the brain, and for the most part, these tend to be benign. Now, the symptoms that a patient will develop with a brain tumor really depends on the location of where is this tumor located and on the size of the tumor. Obviously, the larger it is, the more commonly it will cause symptoms. Now, headaches are by far the most common finding. We see it in up to 60% of patients. Seizures can also occur in about 40% of patients. Now, memory loss, weakness, visual disturbances, abnormalities with language or speech, also cognitive impairment and personality changes all can occur if you have a brain tumor. Again, the bigger the tumor, the more deficit you tend to find, and also depending on the location of the tumor will have a lot to do with the symptoms a patient will have. Now, big teaching point that I want you to keep in mind, and that is that the best test to look for a brain tumor is by far a brain MRI with contrast. Always remember that. So an MRI with IV contrast, which is called gadolinium, is very important. I mean, it's imperative to get a good MRI scan because it will provide amazing detail of the tumor. And our friends, the radiologists, which basically read the MRIs, can tell us. I mean, it's amazing. I can tell you as a treating physician, when I have a patient that the radiologist told me it looks like, for example, a glioblastoma, it's always been a glioblastoma. So that's why it's so important to have a good imaging test. Now, in having such a good test, the radiologist can actually see features that are suggestive of either a benign appearing tumor or a malignant appearing tumor, okay? So that's why it's very important that you obtain the MRI with contrast. Now, if the person cannot have an MRI with contrast, then likely the next best test is a CT scan with IV contrast. Just something to keep in mind. So all of a sudden, we have a patient that has symptoms, and we took a picture of the brain, hopefully an MRI with contrast, and yes, it looks like the patient has a tumor. Well, the next step is to obtain tissue. We want to obtain a biopsy and look at this tissue under the microscope. Now, this sample of tissue can either be obtained through a biopsy, in other words, with a needle, we want to obtain a little piece of tissue, or take the tumor out, and in doing so, we have a lot of specimen to send to the lab. So that's the way that we are going to confirm the diagnosis. So that's why I put on here tissue, and we want to obtain either a biopsy or take the person to surgery. All right, so once the biopsy has been done or the patient has surgery and we send that sample to the laboratory, the pathologist is going to look at it under the microscope. They're also going to do several other tests, which we're going to look at, and they are also going to provide us with a grade of the tumor. This basically means that when they look at it under the microscope, they will tell us how aggressive does it appear to be. And they will grade it based on a score of 1 to 4. So for example, if they tell us that it looks like a grade 1 tumor, then we know we are dealing with a low-grade tumor because the cells under the microscope almost appear normal. This means that this is a slow-growing tumor. And for all intents and purposes, this is a benign tumor, okay? Very slow-growing tumor. The most important thing is that they appear almost normal under the microscope. Now, if you have a grade 2 tumor, okay, a grade 2 is still somewhat of a low-grade tumor, but the cells appear moderately abnormal, okay? And this is a little bit quicker growing than, say, a grade 1 tumor. Now, a grade 3 tumor is already an aggressive tumor. Whenever it's a grade 3, we tend to use the word anaplastic, and you're going to see this in the next few slides. So grade 3 is a high-grade tumor. It is an anaplastic tumor. Obviously, it grows fast, and the cells obviously look abnormal under the microscope. And then the last one is a grade 4 tumor. This is the most aggressive out of all of them. This is a high-grade tumor. It's a fast-growing tumor. And you tend to see necrosis and microvascular proliferation as well. What necrosis means is dead tissue. If you can imagine, you have a tumor that is growing very fast. It is outgrowing its blood supply. So parts of the tumor stay without blood. In doing so, they stay without oxygen, they stay without nutrition, and parts of the tumor start to die off. And that is called necrosis. And that is a clear sign of a high-grade tumor, meaning a grade 4 tumor. So I want you to remember that. Also, microvascular proliferation, it basically means that the area where the tumor is, it's generating new blood vessels, a lot of abnormal blood vessels. If you can imagine, this tumor is growing. It wants to feed itself, so it's making a lot of these new or abnormal blood vessels, and the pathologist can actually see this under the microscope. So both of these are findings of a grade 4 tumor. All right, so you have a tumor, you see a tumor in the MRI scan, you did the biopsy, it looks like an aggressive tumor. The next step is providing or obtaining an IDH mutation status. All that this means is we are going to test the tumor to see if it has this mutation. And the mutation is an IDH mutation. That's the name that it has. And it's either going to have the mutation or it's not going to have the mutation. And if it has the mutation, it's a better prognostic finding, okay? So IDH mutations are better. If it does not have an IDH mutation, then it's called a wild type tumor. Wild type, I want you to remember this, means no mutation, because sometimes on your pathology result, they will put it's a tumor that is wild type, and you will not have a clue as to what they mean. All that means is that it does not have an IDH mutation. So I want you to remember that. And wild type, of course, has a worse prognosis. So now that we know if the tumor is either IDH mutant or IDH wild type, let's take an example of an IDH mutant tumor. So we have a brain tumor. If you're following me here on the diagram, you have a brain tumor. It looks aggressive, and we sent it off, and yes, you have an IDH mutation. Okay, the next step is to perform these 4 tests. Okay, the first one is looking for 1p19q chromosomal co-deletion. So this is a chromosomal study, and all of this is done on the tumor. You don't need to panic. We will also look for an ATRX mutation, a TP53 mutation, and a CDKN2AB mutation. All right? So we're going to test the tumor to see if you have any of these. Now, if you have a 1p19q co-deletion, if the tumor has this, then you have confirmed an oligodendroglioma, period. Okay, very simple. Now, I want you to keep in mind, remember the grade 1, 2, 3, 4? Well, oligodendrogliomas only exist as either grade 2 or a grade 3. There is no grade 1 or grade 4 oligodendroglioma. Okay? So if it's a grade 2, we consider it lower grade or low grade, if you will. And if it's grade 3, it's a high grade. And remember, grade 3s, we use what name? That's right, anaplastic. Remember, all grade 3 tumors are called anaplastic tumors. So this is called an anaplastic oligodendroglioma. Now, at the time of treatment, if you have an oligodendroglioma, you have many options. The most important treatment is surgery, and then you can follow this up with either chemotherapy like PCV or temozolomide. These are different chemotherapy options. Also, you can receive radiation. And since it has an IDH mutation, there's also drugs which are IDH inhibitors. They inhibit the IDH mutation, all right? So these are all potential treatment options of an oligodendroglioma. All right, now let's take another scenario. We have a patient with a brain tumor. It's an aggressive appearing brain tumor. We send it off for an IDH mutation, and yes, it has the IDH mutation. Then what are we going to do? We're going to send for the same 4 tests, remember, as on the prior slide. the 1p19q, the ATRX, the TP53, and the CDKN2AB. All right, now, if the 1p19q is negative, because remember, if it's positive, it's an oligodendroglioma. If it's negative, as in this case, then we are going to look at the other mutations, the ATRX and the TP53. And if that is positive, if any one of those is abnormal, then we know we are likely dealing with an astrocytoma. All right? Now, an astrocytoma can be either grade 1, 2, 3, and 4. Remember, a grade 1 is basically a benign tumor. So that's a benign astrocytoma, and that patient is going to go for surgery. If it's a grade 2, 3, and 4, this is more of a malignant astrocytoma, especially the grade 3 and grade 4. Now, as we stated already, the grade 3 and 4 are fast growing. They're considered malignant, so we want to be aggressive with treatment. Now, remember, anything grade 3 is called anaplastic. So the other name for a grade 3 astrocytoma is an anaplastic astrocytoma. And the only reason I'm going over this is because a lot of times on the pathology slide, they will put grade 3 astrocytoma, or they will simply put anaplastic astrocytoma, and they won't put a grade. Well, now you know they are automatically telling you that it's a grade 3. So that's why it's important that you know this stuff so that you can apply it clinically. Now, if there's necrosis under the microscope, if they see necrosis or they see microvascular proliferation, remember those are signs of a grade 4. We went over that already. Or if you also see a homozygous deletion of CDKN2AB, then you already know that your diagnosis is a grade 4 IDH positive astrocytoma. Okay, IDH positive because remember, it has the IDH mutation. It's grade 4 if it has any of these, okay? Again, the necrosis, the microvascular proliferation, or the homozygous deletion of CDKN2AB. You already know you have a grade 4 IDH positive astrocytoma. Very important that you keep that in mind. Now, continuing with astrocytomas, as far as treatment is concerned, we would take these patients to surgery. If it's a grade 1, we know that's a benign tumor, surgery, and you're done. Most patients are cured. Now, if you have a grade 2 or a grade 3, then you have many options. Again, surgery, you can use an IDH inhibitor because remember, it has an IDH mutation. And you can also give chemotherapy and radiation. And as far as chemotherapy is concerned, you have many options like PCV or temozolomide. Now, if you have a grade 4 IDH mutant astrocytoma, then we treat these pretty much very similar to a glioblastoma. All right, and we're going to get into that now. So the next example, same one. We have a brain tumor, but in this case, it's IDH wild type, meaning they do not have, this tumor does not have the IDH mutation. All right. In this case, we're going to study or look for the following. Is there microvascular proliferation? Is there necrosis? Remember, these are two that the pathologist would see under the microscope, and these are signs or findings of a grade 4 tumor. Okay, you should already know that. We are also going to test the tumor to see if it has an EGFR mutation, if there is a TERT mutation, and or is there an abnormality with a chromosome 7 and 10? In other words, a gain of chromosome 7 and a loss of chromosome 10. And if any of these are positive, then you know that you have a glioblastoma wild type. All right? Another name would be a glioblastoma grade 4 IDH wild type. All right? And the treatment for this is going to be surgery, usually followed by radiation therapy with temozolomide, and then further chemotherapy for up to 6 months. Now, within my channel, I have a video specifically dedicated to glioblastoma. So in this video, we would discuss the glioblastoma wild type that we already mentioned, and the one prior to this, the grade 4 IDH positive astrocytoma, okay, the most aggressive of the astrocytomas that have the IDH mutation. So I really suggest you find this video because it complements and ties in to this video. And there you go. As I said, it was more of an introduction, but I gave you a lot of information. So now you know the approach. If a patient comes in with an aggressive appearing brain tumor, now you know what you're going to do. And chances are it's going to be one of these because these are the most common. But don't forget to always exclude the possibility of a metastatic tumor from another area of the body that traveled to the brain. So all the best to you and thank you.